Third video for nephrology. Let's see what we have here. ARF, acute renal failure, acute tubular necrosis versus pre-renal uremia. So, acute tubular necrosis versus pre-renal uremia. Okay, so it's important to remember that in pre-renal uremia, kidney hold on to sodium to preserve volume. Of course, kidney holds on to sodium, and there's pre-renal uremia. Okay, so what happens is in urine sodium is less because urine is kidneys are holding sodium, as it said before. Fractional sodium excretion is less, urea excretion is less. Urine to plasma osmolality is more than 1.5. Urine to plasma urea is more than 10:1. Specific gravity more than 1020. Urine plant sediment. Response to fluid challenge, yes. Pre-renal uremia is really responses to fluid challenge. But if it's acute tubular necrosis, it's not like that. Urine sodium will be more than 30 millimole per liter. Fractional sodium excretion should be more than 1%. Fractional urea excretion should be more than 35%. Urine to plasma osmolality is less than 1.1%. Less than 8:1 urine to plasma urea. So here urea is a lot high, with less than 10,000 1010 urine. Specific gravity, urine is brown granular cast, and no response to fluid challenge. So that's what you need to know about it. Papillary necrosis. You will have fever, loin pain, hematuria. Intravenous urogram or IVB for pyelogram shows papillary necrosis with renal scarring. Chronic, what are the causes of papillary necrosis? Chronic analgesia use, sickle cell disease, TB, acute pyelonephritis, diabetes mellitus. Now, renal involvement in HIV. May occur because of treatment of the virus itself. Protease inhibitors in Inavir can precipitate intratubular crystal obstructions. This is the one you have to remember. Key points would be prevalence 30% among HIV patients. CKD is increasingly a cause of morbidity among people with HIV. Risk factor for CKD include African ethnicity, hypertension, diabetes, his family history of CKD, CD4 count less than 200, unsuppressed viral load, and HCV infection. HIV infected person with CKD are less likely to receive ART even when ART is indicated. ART should be given to patients with renal disease. If indicated, though, most NRTIs must be dosed according to renal function, and some ARV should be avoided. Alright. So basically, you should not be giving antiretroviral therapy to people with HIV infected patient with CKD, even though it's indicated. So the therapy should be given to patients with renal disease if indicated, though most must be dosed according to renal function. Okay, the presentation for HIV and renal involvement. HIV-associated nephropathy, HAVAN it's called, may present with massive proteinuria, a lot of proteins going out, normal or large kidneys. This is something different. Large kidneys, focal segmental glomerulosclerosis, we have studied it, which also presents with proteinuria, with focal or global capillary collapse and renal biopsy. Collapse. Elevated urea and creatinine, normotension. Management if high viral load or low CD4. Intensify antiretroviral treatment if high viral load or low CD4. ACE inhibitor or ARB if BP and potassium allow. There's evidence of short-term benefit from steroids, but it's not mainstream treatment. So it's kind of difficult because sometimes it may be contraindicated. Management of hypertension in CKD. So this is an important thing. Most patients with CKD will require more than 2 antihypertensives. ACE inhibitor are first line and are particularly helpful in proteinuric renal disease. It decreases proteinuria, diabetic nephropathy. As these drugs tend to decrease filtration pressure, a small fall in GFR and rise in creatinine can be expected. Most nephrologists would accept a change of up to 15% greater than rise than may indicate underlying endovascular disease. Okay. The next thing is furosemide is useful as an antihypertensive in patients with CKD, particularly when GFR falls to below 45 ml per minute. It has the added benefit of lowering serum potassium. High doses are usually required. Okay. Next is Goodpasture syndrome, a very important one. It's a rare autoimmune condition associated with both pulmonary hemorrhage and rapid progressive glomerulonephritis. So when we studied rapidly progressive glomerulonephritis, was this coming up? Let's see. Somewhat there, like it was there. Causes there was cause Goodpasture syndrome. So here you go, pulmonary hemorrhage and rapidly progressive glomerulonephritis. It's caused by anti-GM antibodies, anti-glomerular basement membrane antibody against type 4 collagen, which is also present in the lungs, so will affect the lungs and the kidneys. Goodpasture syndrome is more common in men, sex ratio 2:1, and has a bimodal age distribution, speaking of which it peaks in 2030 or 60 to 70 age bracket. Although many diseases can present with these symptoms, the name Goodpasture syndrome is usually reserved for the autoimmune disease triggered when immunity attacks Goodpasture antigen, that is the type 2 hypersensitivity reaction. Goodpasture is associated with HLA-DR2. So what you need to remember, 3-4 points. Patient may present with hemoptysis and rapidly progressive glomerulonephritis. So this too might make you think about Goodpasture syndrome, which has association with HLA-DR2 antigen and Goodpasture, and then there's antibodies against type 4 collagen, anti-GBM antibodies. These are the things that you need to remember. It's more prevalent among men. Okay, that's not the finish. It's not the end of that. What are the features that you see in Goodpasture syndrome? Pulmonary hemorrhage and followed by rapidly progressive glomerulonephritis. Very important. What do you see in the biopsy? IgG deposits on renal biopsy, anti-GBM antibodies. Okay. Factors which increase the likelihood of pulmonary hemorrhage: young male smoker, lower respiratory tract infection, pulmonary edema, inhalation of hydrocarbons. Investigation will be renal biopsy, linear IgG deposits along the basement membrane. Okay. Increased transfer factor secondary to pulmonary hemorrhage. Lung biopsy will show accumulation of hemosiderin laden macrophages with alveoli. This for lungs. Okay, so management may be plasma exchange, steroids, or cyclophosphamide. Dehydration may decrease the risk of pulmonary hemorrhage. Pulmonary edema increase the risk of pulmonary hemorrhage. Okay, another very important disease which comes up here is hemolytic uremic syndrome. But the thing you have to remember is this is more prevalent in children, young children. So HUS, it's called HUS. So there's like mnemonic of HUS, baby HUS. Generally seen in young children and produces a triad of acute renal failure, MAHA, that is microangiopathic hemolytic anemia, and thrombocytopenia. So when you see this triad in a child, you may think of HUS. So let's see, what are the causes? Post-dysentery, classically Shigella toxin, enterohemolytic. Tumor, pregnancy can cause this for HUS. Cyclosporine, the pill, SLE, HIV. Okay, FBC. The investigation, how do you know that it's HUS? Of course, you will see in the CBC, you will see anemia, thrombocytopenia, fragmented hemolytic blood film, fragmented. So you will see MAHA, fragmented blood film. UNE, acute renal failure, stool culture, every time. Management. Treatment is supportive. What do you do for treatment? Fluids, blood transfusion, dialysis if required. HUS is a rare disease. Clinical trial data are absent. Promising data are, however, now available for the use of azithromycin with good results. The indications for plasma exchange in HUS are complicated. As a rule, with plasma exchange is reserved for severe case of HUS, not associated with diarrhea. Another disease that comes up is Fanconi syndrome, described as generalized disorder of renal tubular transport. It's a RTA2, remember. Features type 2 renal tubular acidosis, aminoaciduria, glycosuria, phosphaturia, osteomalacia, causes lupus cystinosis, Sjogren's syndrome, multiple myeloma, nephrotic syndrome, Wilson's disease. Just need to remember the causes and the features. So the features, you can see what are the things that's going out: amino acid, glucose, phosphate, and stimulation. These 3 will go out of the urine. Some of the associations are actually hard to remember with your knowledge, like you just have to recall them because there's no other way to remember. Okay, now coming to the inherited renal disorders, which are a few which you have to also know by heart. ADPKD is the most common inherited cause of kidney disease. Most common, autosomal dominant, affecting 1 in 1,000 Caucasians. 2 disease loci have been identified, PKD1 and 2, which code for polycystin 1 and polycystin 2. So type 1 will have problem in chromosome 16, presence with renal failure earlier. Type 2 is like less prevalent, but it doesn't present with renal failure earlier. It's chromosome 4 problems. Presentation will be vague, loin or abdominal discomfort due to mass, since it's polycystic kidney disease. Acute loin pain or renal colic due to hemorrhage into a cyst. Hypertension, hematuria, UTI or cyst, renal failure. The screening investigations, where there is abdominal ultrasound, that's what you do for checking. Ultrasound diagnostic criteria in patient with positive family history. In less than 20 years age, CT scan is not needed. Less than 20 years age, ultrasound gives false negative. Okay. In 2 cysts, unilateral or bilateral, if aged less than 30. 2 cysts in both kidneys if aged 30 to 59. 4 cysts in both kidneys if aged more than 60 years. Ultrasound diagnostic criteria. 4 cysts in both kidneys if aged more than, okay. Associated, this is for patients with positive family history. Anyway, associated conditions might be colonic diverticular with any related symptoms screened by barium enema. Mitral valve prolapse needs screening. What are the things you can do for treatment? Give painkillers. UTI, don't give antibiotics. Increase BP control. Target should be less than 110/70. ESRD, go for transplantation. Now the other type is the autosomal recessive polycystic kidney disease. It's much less common than ADPKD. It's due to a defect in gene located on chromosome 6. That was for 16 and 4, and this one is 6. Diagnosis may be made on prenatal ultrasound or in early infancy with abdominal masses and renal failure. So ESRD develops in childhood. Patients also typically have liver involvement, for example, portal and interlobular fibrosis. So there's liver and renal involvement, basically. Alright, the next thing is important as well. Alport syndrome is usually inherited in an X-linked dominant pattern, X-linked. In 85%, 10 to 15% would be autosomal recessive and rarely as autosomal dominant. It's due to a defect in the gene which encodes for type 4 collagen. So we just studied about type 4 collagen, antibodies against them. What was that? Goodpasture syndrome. So in Alport syndrome, it's also a defect in type 4 collagen resulting in an abnormal glomerular basement membrane. So this is not about an antibody against it, but it's like an abnormal membrane. This is more severe in males, with females rarely developing renal failure. A favorite question in the MRCP is an Alport's patient with a failing renal transplant. Okay. This may be caused by the presence of anti-GBM antibody. Okay, this is also linking with that, linked to a Goodpasture syndrome-like picture. Alport syndrome may present in childhood with the following features may be seen. So it can also happen in childhood, just like in Huss. It was in childhood. Huss, baby Huss, and Alport, like, I don't know, you can make up a new mnemonic for that. Microscopic hematuria. In childhood, it may present like this: microscopic hematuria, progressive renal failure, bilateral sensory neural deafness, lenticonous protrusion of the lens surface into the anterior chamber, retinitis pigmentosa. So there's a lot of ears and eyes. There's like eyes, there's ear, and there's kidney, and there's hematuria in the kidney. So this is like involving everything. It's Alport syndrome. So it's like a mixture of many symptoms that you have to remember: microscopic hematuria, progressive renal failure, bilateral sensory neural deafness, lenticonus protrusion of the lens into the anterior chamber, and retinitis pigmentosa. That is also explained. Okay, phenylketonuria. This is another type of autosomal recessive condition caused by disorder of the phenylalanine metabolism. Is due to a defect in phenylalanine hydroxylase, an enzyme which converts phenylalanine to tyrosine. So remember the phenylalanine PAL to tyrosine. So this is the process, PAL to tyrosine. So there's this enzyme phenylalanine hydroxylase which converts it to it. High levels of phenylalanine leads to problems such as learning difficulties. So since this one is absent, so the hydroxylase thing is absent, so that's what leads to increased phenylalanine. High levels of phenylalanine leads to problems such as learning difficulties and seizures. The gene for phenylalanine hydroxylase is located in chromosome 12. Incidence of PKU, okay, just say PKU is 1 in 10,000, so it's like a lot. It's pretty less. Okay, usually presents by 6 months with developmental delay. So classically has fair hair and blue eyes, learning difficulties, seizures, eczema, musty odor to urine and sweat, secondary to phenylacetate or phenylketone. Okay, diagnosis will be Guthrie test, the Hill prick test done at 5 to 9 days of life. Also look for the other biochemical disorders such as hypothyroidism, hyperphenylalaninemia, phenylpyruvic acid in urine. Okay, management, poor evidence to suggest strict diet prevents learning disabilities. Okay, dietary restrictions are however important during pregnancy, as genetically normal fetus may be affected by high maternal phenylalanine levels. Alkaptonuria. Okay. All this is also autosomal recessive disease, and this presents with black urine disease. It's also called black urine disease. Rare inherited genetic disorder of phenylalanine and tyrosine metabolism. This is also in the same metabolism problem. Autosomal recessive, common in Slovakia and Dominican Republic, due to defect in the enzyme homogentisate 1,2-deoxygenase, which participates in the degradation of tyrosine. Okay, now tyrosine also gets, like, this, there was this PAL, and then there was this tyrosine, and this is hydroxylase. Now tyrosine also degrades, right? As a result, the toxic due to a defect in the enzyme which participates in the degradation of tyrosine. So tyrosine degrades, right? So there's this enzyme which helps it to degrade. As a result, a toxic tyrosine byproduct called homogenistic acid accumulates in the blood. So there is a byproduct which gets accumulated in the blood and is excreted in the urine in large amounts. It's called homogenistic acid which gets built up. Okay, excreted in the urine. So excessive homogenistic acid causes damage to cartilage. So of course some problems linked to osteoarthritis and heart valves, as well as precipitating as kidney stones. Okay, the features might be often asymptomatic. Dark skin, sun exposed areas and around sweat glands. Kidney stones and stone formation in the prostate are common and may occur in a quarter of the cases. Low back pain at young age due to the accumulation of homogenistic acids in joints. Cartilage damage may also occur in the hip and shoulder. Joint replacement surgery, hip and shoulder is often necessary at young age. Valvular heart disease may mainly calcification with agitation may happen. Distinctive characteristic of alkaptonuria is the ear wax exposed to air turns red or black depending on diet after several hours because of the accumulation of homogenistic acid. Okay, treatment with nitisinone, which suppresses homogenistic acid production, is being studied. So, alright, next is cystinuria. It's an autosomal recessive, again, another autosomal recessive disorder characterized by the formation of recurrent renal stones. So something which you see, it's due to the defect in the membrane transport of cysteine, ornithine, lysine, arginine, cola, this mnemonic cola. So, what you need to remember is Recurrent renal stones, yellow, classically yellow and crystalline, appearing semi-opaque in X-ray. Crystalline, okay. Hydration, depenicillin, urinary alkalization. Diagnosis would be cyanide nitroprusside test on chromosome 2 and 19. These genes are affected. Just remember. Okay, the next one would be homocystinuria, another autosomal recessive disease. So all these diseases might be confusing to you. So I will just go back and just check out the highlights again after a while after finishing this. Homocystinuria is autosomal recessive disease caused by deficiency of cystathione beta synthetase. Deficiency of that. This results in accumulation of homocysteine, which is then oxidized to homocysteine. I don't understand that. Features: often patients have fine fair hair. It looks similar to phenylalanine disease. Musculoskeletal might be similar to Marfan's arachnodactyly. Neurological patient may have learning difficulties, seizures, ocular. Downward dislocation of lens. Marfans have upward dislocation of lens. Very important. Increased risk of arterial and venous thromboembolism except coronaries, Muller flash liver reticulars. Diagnosis may be made by cyanide nitroprusside test, which is also positive in cystinuria. Treatment is vitamin B6. So a lot of AR diseases, like it was very, very confusing. ADPKD was all autosomal dominant and it's totally different. Okay, so you know the thing. The problem starts from Alport syndrome. The autosomal recessive PKD is also chromosome 6 recessive. Alport syndrome is X-linked, and then there's this type 4 collagen problem, and then the patient is present in the childhood with microscopic hematuria, progressive renal failure, deafness, lens dislocation, protrusion of the lens in the anterior chamber, retinitis pigmentosa, and then phenylketonuria is like a autosomal recessive, and then it has this thing that phenylalanine converts to tyrosine, and there's enzyme which helps it. So there's lack of that enzyme causing phenylalanine to store up in the blood, causing developmental delay, fine hair, and then learning difficulties, seizures, and everything. And then you manage it with just make sure that the diet may help a bit. Alkaptonuria is like when there's a lot of homogenistic acid, which is a byproduct of tyrosine. There's this enzyme which helps break down tyrosine, which doesn't work or is not there. So there's this build-up byproduct of tyrosine is homogenistic acid, which builds up in the blood and causes problem in cartilage and accumulates in the urine, shows black urine, might cause osteoarthritis, heart valves, and kidney stones. And so this osteoarthritis, so this back pain, low back pain, valvular heart disease, and this might occur in childhood as well. Cystinuria, on the other hand, although this one, captonuria, you treat it with nitisinone. Cystinuria is another AR disease, autosomal recessive, which causes recurrent renal stones. You remember the name of cola, cysteine or methionine lysine arginine, which is the effect in this membrane transport, causes this, and features with renal stones, recurrent of them, classically yellow and crystalline, semi-opaque on X-ray. Manage it with hydration, depenicillamine, urinary alkalization, and defects in chromosome 2 and 19. Diagnosis with cyanide nitroprusside test, and homocystinuria is similar. Diagnosed with cyanide nitroprusside test, treated with vitamin B6. But what happens is, it's an AR disease. Deficiency of this thing results in an accumulation of homocysteine, which causes fine hair, fair hair, musculoskeletal, maybe similar to Marfan's, neurological problems like learning difficulties, seizures, ocular downward dislocation of lens. Marfan has upward dislocation, and then risk of thromboembolism, Muller flash liver reticulars. Okay, that's it. That was a revision, and then now the last portion, which is like almost like a few pages left, is basically urological issues. Okay, renal stones. Okay, renal stones. The risk factors might be dehydration, hypercalciuria, a lot of calcium, hyperparathyroidism, hypercalcemia, cystinuria, not cystinosis. Okay, cystinuria, high dietary oxalate, renal tubular acidosis, medullary sponge kidney, polycystic kidney disease. This might be the risk factors. Beryllium, cadmium exposure, drugs that promote calcium stones like loop diuretics, steroids, acetazolamide, theophylline, Thiazides can prevent calcium stones. Increase distal tubular calcium reabsorption more in male than female. Okay, risk factor for urate stones would be gout, ileostomy, loss of bicarbonate fluid results in acidic urine, causing the precipitation of uric acid. Okay, the types of stones that are there. Calcium oxalate is the most. 80% will be opaque, radio opaque, mixed calcium oxalate phosphate stone. 10% opaque, triple phosphate stones opaque, calcium phosphate opaque. Urate stones are radiolucent, and then crystalline stones semi-opaque, ground glass appearance. We were talking about that a few moments ago. Xanthine stone radiolucent. Okay, so staghorn calculi, since they resemble horns of a stag, they are most commonly composed of struvite, magnesium ammonium phosphate, caused by infection and forming under the alkaline conditions induced by urea splitting bacteria, but may be composed of uric acid, cysteine, or calcium oxalate. Monohydrous staghorn calculi involve renal pelvis and extend into at least two calyces. Uroplasmic, okay, it's not very much important here. How do you prevent this renal stones? It's important. Uric acid stones, allopurinol, urinary alkalinization, or bicarbonate. Okay, oxalate stones, you can give cholestyramine, decreases urinary oxalate secretion. Pyridoxine decreases urinary oxalate secretion. Calcium supplement can also decrease urinary oxalate. For calcium stones, you go for, this is for oxalate stone. Okay, cholestyramine, pyridoxine, calcium supplement, and allopurinol for uric acid stone. All of them were opaque. Yes, the urate stones were radiolucent, and then the xanthine stones were radiolucent as well. So okay. Anyway, for calcium stones, high fluid intake is a must, and then low animal protein, low salt diet. At low calcium diet has not been shown to be superior to whatever. Thiazide diuretics increase distal tubular calcium resorption. Stones, if less than 5 mm, will usually pass spontaneously. Less than 5 millimeters. Lithotripsy may be required. Okay, acute management of renal colic, NSAID by any route, combination with paracetamol is helpful. If NSAIDs are in contraindicated or insufficient, IV paracetamol. Okay, next step is an opioid analgesic, tramadol. Do not offer antispasmodics to people with suspected renal artery colic. Not useful at all. Okay, BPH is a common condition seen in older men. Main risk factor is age. 50% of 50-year-old men will have evidence of BPH, and 30% will have symptoms. Around 80% of 80-year-old men have evidence of BPH. Okay, BPH typically presents with lower urinary tract symptoms like LUTS. There are several types of symptoms, that is, voiding symptoms like obstructive, weak or intermittent urinary flow, straining, hesitancy, terminal dribbling, incomplete emptying. Stored symptoms like irritative, like urgency, frequency, urinary urgency, incontinence, nocturia, post-micturition dribbling, and then complications like UTI, retention, obstructive uropathy. Okay, BPH, LUTS, decreased PSA, prostate cancer, no cancer symptoms, no obstructive symptoms. PSA is very high, LP is high. DRE, we can check, do DRE smooth and median, sulcus is palpable, firm and hard, median sulcus not palpable. Okay, so management options is basically watchful waiting. Okay, medication alpha-1 blocker, 5-alpha reductase inhibitor. The use of combination therapy was supported by the medical therapy of prostatic symptoms. Surgery, you can go for TURP, transurethral resection of prostate. Alpha-1 antagonists can be given like tamsulosin, terazonin, toxazosin, alfuzosin. Decreases the smooth muscle tone of prostate and bladder. Considered first line, improves symptoms in around 70% of men. Adverse effect may be dizziness, postural hypotension, retrograde ejaculation, and dry mouth, and all that. Okay. 5 alpha reductase inhibitor like finasteride. So okay, this one is known as Euromax in some places. Okay, let me just write it here. If prostate is estimated to be more than 30 gram or PSA more than 1.4, block the conversion of testosterone to dihydrotestosterone, which induces BPH. Um, Unlike alpha 1 antagonists, cause a reduction in the prostate volume and hence may slow down the progression. Okay, this is very important. Reduction in prostate volume. This one. Okay, then takes time and symptoms may not improve for 6 months. May also decrease PSA concentrations by up to 50%. Adverse effect may be erectile dysfunction, libido, ejaculation problems, decreased libido, ejaculation problem, gynecomastia. Next is prostate cancer. This might be not. This might not be like MRCP type questions, but sometimes they are coming up. It's the most common cancer in men and makes up to 30% of all male cancer diagnosed in the UK. Higher incidence of morbidity and mortality from prostate cancer in men of African Caribbean origin compared with white Caucasian men. Okay, risk factors will be age, family history, ethnicity, black more than white, more than Asian. BP is not a risk factor. Okay, this is important. Some people might think BP is a risk factor. Management T1 or 2. T1 clinically unapparent, life expectancy less than, watchful waiting, if more than 10, then prostatectomy or radiotherapy. T2 defined to prostate, you just do surgery or radiotherapy. T3 beyond prostatic capsule. T4 involves bladder, neck, or rectum. Most men will have occult meds managed with radiotherapy. Important. Disseminated disease hormonal therapy, synthetic GnRH agonist or synthetic GnRH which provides okay. I really don't want to go through this. It's like something not very necessary. Renal cell carcinoma. Okay, it's also known as hypernephroma and accounts for 85% of primary renal neoplasm. It arises in from proximal renal tubular epithelium. More common in middle-aged men, smoker. Okay, this is also very much associated with von Hippel-Lindau syndrome, tuberous sclerosis. Incidence only slightly increases or ADPKD. CT diagnosis will be CT scan plus contrast shows contrast enhancing mass. Okay. Features may be hematuria, low and pain abdominal mass. This is the triad. Pyrexia of unknown origin. Left varicocele. Reduction of left testicular vein. Endocrine effects may secrete erythropoietin, may cause polycythemia, parathyroid hormone, hypercalcemia, renin, ACTH. 25% have metastasis at presentation. Management would be radical nephrectomy for confined disease. Alpha interferon and interleukin 2 have been used to reduce the tumor size and also treat patients with metastasis. Receptor tyrosine kinase inhibitor like sorafenib have been shown to have superior efficacy compared to interferon alpha. Okay, so next part is Wilms tumor or nephroblastoma. Is more common in childhood. Childhood malignancy, less than 5 years old, median 3 years old. Features would be abdominal mass, painless hematuria, flank pain, anorexia, fever. Unilateral 95% of the case. Metastases are found in 20% of patients, most commonly lungs. Nephroblastoma. So all the blastomas are usually coming up in childhood. Most common metastatic secondary tumor that was a solitary round shadow in chest cavity is renal in origin. Okay, management will be nephrectomy, chemotherapy, radiotherapy. Prognosis is good, 80% cure rate. Association can be hemihypertrophy. Around 1/3 of cases are associated with mutation in WT1, Walker syndrome, chemical degeneration, Beck-Whiteman syndrome. Please remember the names. Bladder cancer is a common urological cancer, with most cases being transitional cell carcinomas. It has a 3:1 ratio in male, with women generally having a worse prognosis than men. The most classical presentation is with gross painless hematuria. Associated with smoking, occupational aniline dyes used in printing and textile industry, rubber industry, aromatic amines, prior radiation treatment to the pelvis, exposure to the urinary metabolite of cyclophosphamide, schistosomiasis, okay, mutations in 17p, 13 mutation in NP, okay, drugs will be Cyclophosphamide. No significant correlation between bladder cancer and coffee consumption, artificial sweetener intake, or aspirin injection. That's it for nephrology.